So hello everyone, I want to introduce you to the first episode of PT Forensics. I'm sitting here with my good friend Corey. We will introduce ourselves in a little bit, but first I just want to break down a little bit about what this podcast is all about. Our idea is to take an evidence-based look at specific patient cases. So the plan is we will both present a research article. From there, we will discuss a patient case and how it all comes together and how we can take this evidence-based approach and apply it to real, actual patients. So to start, my name is David. I am a physical therapist currently working in Connecticut, and my specialty, I guess you could say, is orthopedics and sports as well. So that it will be the focus of what I look for. And this is my friend Corey. Take it away.
Thanks, Dave. My name's Corey. I'm also currently working in Connecticut in outpatient orthopedics. What we really want to do with this PT Forensics podcast is allow therapists to come together and listen to what we have to say regarding specific patient cases, but also hear about a few different research articles that might be relevant. And be able to, apply those articles to the patient case in the podcast, but hopefully bring something back to your own patients. Again, I'm working in orthopedics in Connecticut. I see a lot of direct access patients from, your athletes, CrossFitters, golfers, all the way to just general falls and balance assessments, standard orthopedic injuries, and I also treat a little bit of a vestibular patient caseload as well. And again, what we're going to do here today is talk about our first patient case, which is a patient with a partial thickness rotator cuff tear. It's a pretty common presentation, I would say I see quite frequently here in my clinic. 56-year-old male presenting with right shoulder pain. The pain started gradually while typing at his desk or driving home. So this is your classic fellow who sits most of his day, shoulders very protracted, even upon walking. Gets a little bit more exaggerated when he's sitting. And what did he do? Of course, he went right to his orthopedic, who then ordered an MRI, diagnosed him with a rotator cuff tear. Coming in, he wasn't so sure if it was full thickness or partial thickness. Don't think he even really cared, but this patient was very, very nervous initially that when he moved his arm, he was going to start to tear that arm worse. So a very high level of pain and a very high level of fear. And he's worried he needs surgery. So he comes to me and says, hey, I tore my rotator cuff and I'm not sure why I'm here to exercise, but my doctor told me I had to. Is this a patient case that you see pretty frequently, Dave?
Yeah, so I was actually just about to jump in there as well. So I see this very frequently, and before we were even talking about what patient case we would discuss, I had a very, very similar patient walk in as well. He had severe right shoulder pain. He is more of a maintenance worker, so a very manual labor type based guy. And he complained of increasing pain, and he was very worried, as your patient was as well, about needing surgery or whether he would need surgery, if he would be able to return to work, and that whole dynamic. So very similar patient case that I've experienced. I think this is very common amongst physical therapists in the orthopedic space as well. And yeah, that's very similar. So I think everyone listening could kind of relate to what we're talking about right now.
Certainly. So where I went from a research perspective is I started to look at the role that pain plays in shoulder pain, and specifically in patients with rotator cuff tears. So we'll go right into the article here. The article links are posted below. The first article we're going to be talking about here is the title of it is Symptoms of Pain Do Not Correlate with Rotator Cuff Severity. So it kind of gives you the bottom line right off the title there. It's published by Dunn et al. In the Journal of Bone and Joint Surgery in 2014. We're going to kind of quickly just go through the background and methods, just to kind of get you acquainted with what they were studying, and then I would definitely want to talk through some of the conclusions and some of the takeaways for you to bring back to your patients. So the authors use a cross-sectional design of 393 patients with a symptomatic, atraumatic, full-thickness rotator cuff tear. So pretty similar to our patient there. And they wanted to determine whether or not pain severity was related to rotator cuff severity. Now, in some disorders, such as osteoarthritis, pain severity is often linked with disease severity and can often be used to determine when to intervene, let's say with a total knee replacement. However, rotator cuff tears tend to be a little bit less predictable. We understand now that many people have full or partial thickness rotator cuff tears that have no pain. And there's much debate now in the literature as to what the pain producer actually is in a painful shoulder. And I think it might be a different pain generator from case to case. But with that said, good luck trying to talk down that patient who walks in with his MRI in hand, like this patient here, and says, listen, my rotator cuff is torn. You might not want to just go in and say, yeah, I don't really care about that, because it is relevant. Now, I think this article does give you some important educational points that you can use for this specific patient to diffuse the patient's worry and angst and help kind of develop that therapeutic relationship. So this study was performed by the Moon Shoulder Group, which stands for the Multi-Center Orthopedic Outcomes Network, and that was a team of 16 fellowship-trained orthopedic surgeons. And they basically brought this group together to conduct large multi-center research studies on the shoulder. Now, they state outright that the indications for surgery for an atraumatic rotator cuff tear are not clear. And they admitted to not even being able to come to a consensus on these indications among the 16 surgeons there. So the group was looking for insight into risk factors for failure of non-operative treatment to better define the indications for surgery. Pain was one of these factors that they explored, and they wanted to see if it should be included in the surgical criteria. For this study here, quickly, exclusion criteria was a previous injury that precipitated the pain, pain determined to be related to the cervical spine, scapular pain, previous shoulder surgery, glenohumeral arthritis, inflammatory arthritis, adhesive capsulitis, a previous proximal humerus fracture, symptomatic contralateral rotator cuff tear, and dementia. So those are the patients not included there. Now, to evaluate this association, looking at pain and other baseline factors in regards to the rotator cuff severity, they use a multivariable linear multiple regression model. They fit it in use of a continuous analog scale. So they kind of used a 0 to 100 pain scale as the dependent variable. Now, the other variables that they were looking for correlation was age, sex, BMI, duration of symptoms, activity level, handedness, education, occupation, race, smoking status, patient expectations, the specific tendons that were torn, retraction of the tendon, humeral head migration, and the amount of atrophy in the supraspinatus. So they were looking at all those things to see if they had any correlation with pain severity. You can get a detailed explanation of the methods and characteristics of the patients in the study itself. I just kind of want to get to some of these articles' conclusions here. So what they found was that measures of tear severity, including the tendons involved, the amount of retraction of the tendon, the presence of humeral head migration, and the amount of fatty degeneration of the supraspinatus were not associated at all with pain. They did find a slight association with the number of comorbidities that the patient had, a lower education level, and race, but these disparities were not really clinically meaningful on the visual analog scale, which they determined was 1.4 centimeters in patients with rotator cuff disease. So it was below that threshold. So in this discussion of the article, they bring up a few great talking points that you can definitely bring back for your patients. I want to actually directly quote a few sentences from this study by Dunn et al. First one being, they come right out in the conclusion saying, non-operative treatment of symptomatic, atraumatic, full-thickness rotator cuff tears is successful in approximately 75% of patients. Right there, that's the first one you lead off with, is a good amount of patients are going to get much better non-operatively from symptomatic, atraumatic, full-thickness rotator cuff tears. So the article goes on to say patients who have had a failed repair of a rotator cuff tear are often pain-free, and their outcomes may be indistinguishable from those in patients with an intact repair. So they might have a rotator cuff repair surgery that they failed, so they retore, and they might still be pain-free. Finally, the presence of an asymptomatic rotator cuff tears is high. And if one uses a conservative estimate that 10% of the population over the age of 65 years in the United States has a full-thickness rotator cuff tear, then on the basis of a 2010 census data, more than 4 million citizens in the U.S. have a full-thickness rotator cuff tear. Now, from this very large number as a denominator and the approximately 250,000 rotator cuff surgical procedures performed each year in the United States as a numerator, only 6% of patients with a full-thickness rotator cuff tear have surgery each year. These different lines of evidence suggest that many rotator cuff tears are not associated with pain. End quote. Now, in the conclusion, they state, another quote, because the relationship between pain and the presence of a rotator cuff tear is not robust, when a patient presents with pain as the primary symptom, it may not be accurate to assume that the accompanying rotator cuff tear is responsible for the pain. That's kind of the big takeaway there. Now, any one of these statements from the article can be used as an educational piece for patients and for doctors. Studies like this might be a good one to bring to the doctor when you're trying to, maybe your primary care doctor, you're trying to bargain to get a few of those shoulder pain patients, instead of sending them right for an MRI, to send them to you first, if you live in a direct access state. Now, in order to move towards applying that article to the patient case, I think it's important to talk about therapeutic relationship. And in this patient, it's especially important. The therapeutic relationship in physical therapy is one that fosters healing and movement. And the patient in this patient case has a very high level of fear regarding his shoulder. And I would suggest that you quantify that. One of the things I like to use in the clinic here is the FAB-Q. And you can use the FAB-Q. It's usually has low back pain in most of the questions it asks. So fear related to low back pain. But you can just substitute low back pain for shoulder pain. Dave, have you ever used that in the clinic?
Yeah, I use it, I wouldn't say often, but every now and then I definitely do. I think it's a great tool, kind of like what you said, to bring out that psychosocial type aspect to what people are complaining about, especially when they come in and talking about, I have so much pain and, it's just pain this, pain that, when someone mentions this pain, 17 times in 3 sentences, then you got something else to focus on for sure.
And they might come out and tell you, I'm afraid to move, or I fear that this is not going to get better. And when you start to hear a lot of those terms, especially related to fear, the FAB-Q is a good one to go to. And it's a good way to unpack some of those patients' beliefs about a shoulder pain, right? So it has some specific questions, targeted questions that you might be able to just pull them right up and say, hey, listen, I want to talk about some of these answers. And that might be a good lead into a nice therapeutic relationship. So now, as with all patients with a high level of fear, education is obviously going to be key. Now, one of the things you want to make the patient believe right off the bat is that we can offer them a valuable service at a high rate of success, which we know through the research and through the evidence here. And once you can make that patient believe that, you've started to make them believe that they can get better. Now, we know from this aforementioned study that pain is not associated with rotator cuff severity. The patient in this patient case has a very high level of pain, and he's been a little bit resistant to exercise because he knows he doesn't want to tear this rotator cuff any further. I find it useful initially on day one to kind of help calm pain to use isometrics. Dave, do you use isometrics pretty often with some of your high pain level patients? Yeah,
I mean, it's a good way to sort of get the blood flowing, right? Get everything pumping without actually having to move, which is usually, as you had mentioned, movement really creates that fear and that pain in people. So, I think isometrics are fantastic. Something I've noticed with isometrics, I don't know if you could, if you've seen this as well, but usually whenever people do isometrics, they give it like all their might, right? So they just push 100,000% as hard as they can. And that very oftentimes makes things worse.
Right.
Because they're getting this huge co-contraction throughout their body. And if anything, again, it's overstimulating some of those pain receptors. So again, what I usually...
Valsalva.
Right, yeah, they do a little Valsalva in there. So, I mean, what I usually like to do with people... is graded on a percentage, right? So I say, only push about 20-30%, very low, just a little bit, try to get some of that activation going. So again, I like isometrics, but even with an exercise as simple as isometrics, I feel you really have to watch what they're doing and really be aware of what's happening with them.
Yep, to educate, absolutely. And along those same lines, I like to almost use a pain level threshold. So Isometrics really, I think, if like you're saying, if you were to grade on 30-50% of how much you think you can contract that muscle, initially, if they have very high pain levels, it might be a case where everything still hurts. So usually on those very, very high pain intensity patients, I kind of use a 1 to 2 out of 10 pain level threshold. They use a lot of this research with different sorts of tendinopathies, Achilles tendinopathy, patellar tendinopathies. And I think using that, giving them a ceiling of, hey, listen, initially when you start to move the shoulder and maybe not even move, maybe just start to produce some muscle contractions, you might feel a low level of pain, but we just want to make sure you're not getting past a 1 out of 10 or a 2 out of 10. And that allows them a little bit of room to explore maybe what a repeated contraction does or a repeated range of motion. Now, I doubt, obviously, for this patient that an overhead power snatch would be a good day one exercise, right? So a big part of the education, too, is determining what the patient's goals are and specifically, what sort of things he's having trouble with and what he wants to get back to. And you want to start to bring his confidence up early in that rehab process. So maybe day one, you're using isometrics in a rhythmic stabilization. A lot of times I'll bring folks, if they can't tolerate being out at 90 degrees abduction, you can kind of do it at the patient's side or maybe in 45 degrees of abduction, working rhythmic stabilization of internal external rotation. That's a great way, I think, to start to introduce an isometric contraction that's pain-free, start to develop a little bit of a neuromuscular connection between those muscles. Because remember, prior to this patient did not want to move those muscles at all because it hurt. But if you can get them in a nice open pack, loose pack position, they usually can tolerate it very well. Now, eventually the exercises must be progressed, right? Can't do isometrics forever. We want to include concentric and eccentric phases, introduce load, and must be functional, of course. We're going to get into a lot of different treatment episodes in regards to the shoulder, in regards to a lot of other conditions. But we do know generally that E-stim and ultrasound are largely ineffective to treat mechanical shoulder pain. And of course, at the end of the day, we're going to go through some of these treatment things, but there's lots of ways to treat shoulder pain. And it's going to be dependent on what their history is, what subjective and objective findings you find, and what your assessment of the patient's problem is. So, big takeaway from this first article here is that pain level really should be fairly low in your diagnostic value. This specific patient case came from a doctor, but let's say he came in off the street and he just had a very high pain level. What we know is that because he has that high pain level, it might not necessarily mean that he has a severe rotator cuff tear. You're going to want to go through your full subjective and objective testing in order to determine what you think the problem is. The patient may have, there's patients with rotator cuff tears have very high pain levels. There's patients without rotator cuff tears that have very high pain levels, and patients with a tear might have no pain at all. The mechanisms for the pain could just as easily be coming from protective muscle guarding, central sensitization, or a poor scapulohumeral rhythm. And you can educate your patient on this. You could tell them that really a loss of function or a marked loss of strength might be a better predictor as to whether or not to explore those surgical options. And for this patient case, I think that's especially important because he's coming right to you and saying, listen, I don't know why I'm not getting surgery. It seems like exercise is going to make it worse. And you can sit here and tell him, listen, we want to start to track what sort of motions hurt, what sort of functions you're having difficulty with. And we have specific tests that can tell us whether or not this rotator cuff tear is significant enough to warrant surgery. Some of these tests that we all know as PT is the drop arm test, external rotation lag test, and the belly press test. And all of that in concert, of course, with the patient's functional level and goals. Now, lastly, there is a risk of full thickness tears worsening based on the current evidence, but I think that's going to come down to us being good physical therapists at the end of the day. Close monitoring of the patient's progression of exercise will help aid in preventing or not necessarily preventing, but from making any worsening of that rotator cuff tear and following it if there is any worsening. And this patient might also benefit from you looking at his personal exercise program. Given that the patient sits for 40 hours a week, it might be safe to assume this guy has tight pecs and protracted shoulders, which is decreasing his subacromial space. Now, does this sound like someone who should be pushing 60 pounds overhead in an overhead press machine? Probably not. Careful progression of exercise, especially what he's doing when he's not in the clinic, could help this patient achieve the exercise gains he desires while maintaining a low risk of worsening that rotator cuff tear. Dave, you want to take us away on your article?
Yeah, let's do it. Thanks, Corey, for that article. Pain is such a big, important factor in just sort of the rehab process, so much appreciated. Moving forward, my article is a little bit different. My article sort of came more from the surgeon's perspective. It was written by Matthewson et al., and it was based out of the orthopedic surgery department at the University of Calgary. The article is titled Partial Thickness Rotator Cuff Tears, Current Concepts. So it's a review article, goes over a lot of different things, and kind of just a summary of each little item is what we'll get to today. The certain topics that we'll go through are anatomy, etiology and pathogenesis, diagnosis, classification, non-operative treatment, operative treatment, and lastly, a little bit of biologic adjuncts. So it gets a little bit of everything at the end there. So just jumping in, we all kind of get an idea of what the rotator cuff is, right? Four tendons, supraspinatus, infraspinatus, teres minor, subscapularis. So all these kind of just make a horseshoe almost around the humeral head, and it's actually been shown, there's been some anatomical studies, we'll go with that, that show that the fibers of the supraspinatus actually have been shown to make more of like a turn around the greater tuberosity. It's more of like a curvilinear insertion is what they talk about, instead of more of just that straight type of approach. So it's even something that you have to think about with that curvilinear approach with the supraspinatus when you're even developing therapeutic exercises for it, because it doesn't have that straight-on approach. So when you're thinking about it, right, if you are thinking about these isometrics, right, and you're trying to think about the supraspinatus a little bit, you might have to want to think about changing the rotation of the shoulder to try to get a better alignment with that tendon. So interesting stuff there. As far as just like the general prevalence and whatnot of rotator cuff tears, it ranges from 13 to 32%. And there's a strong correlation with patient age. So there's actually a linear increase in the prevalence of rotator cuff tears after the fifth decade of life, even, where more than 80% of people greater than the age of 70 were shown to have a partial thickness rotator cuff tear. So again, as we start to age, as we start to unfortunately degenerate a little bit, the signs of partial thickness rotator cuff tear and even full thickness rotator cuff tear starts to increase. There's different parts of the rotator cuff where it could be damaged. So you're looking at intratendinous, you're looking at the articular surface and the bursal surface of these tendons. So different ones, different locations of these tears could play into the surgical mindset of how they want to correct for this. Moving forward, there are both intrinsic and extrinsic factors that come into play. We were sort of talking about this a little bit with the subacromial impingement as well. So some of the intrinsic factors are age, mostly age-related changes. So what happens as we age, we get decreased vascularity of the tissues, and other sort of changes at the cellular level. Looking more extrinsically, you're looking at, like we discussed, subacromial impingement, instability of the shoulder, as well as internal impingement. So these are all things that can promote partial thickness or full thickness rotator cuff tear. There is a significant correlation between the risk of tear progression and the amount of tendon thickness that has been torn. So it has been shown that you're really looking at this 50% range, really, right? So if you have a partial thickness tear that's greater than 50%, there's more of a likelihood of tear progression as far compared to those with less than 50% of their tendon torn. You'll only, very minimal, is shown 14% had tear progression. So that's a very important thing to look at and discuss with patients. I don't know, Corey, if you've gone over this with some of your patients, or if they come in and they just sort of shout, "Oh my God, I have a rotator cuff tear," and then they go crazy about it.
For sure, yeah, and especially in those patients who are less than 50%, it's a reassuring thing that you can give to them is very low rates of patients who have less than 50% of that tendon torn progress to a full thickness tear. So that can be a very comforting thing and might help to delve into that fear aspect a little bit.
Right, and especially if you get a report from the MRI from the radiologist and they say mild tearing, usually you're thinking like less than 25%, right? Is usually
right.
is what I would think with that. So again, definitely a comforting thing to get to these people. So diagnostically looking at it, obviously, yes, you got signs and symptoms you want to look at. So usually they have a painful arc of motion. They'll have some crepitus, weakness. They'll have a positive impingement sign, really any kind of movement of the shoulder, right? What we talked about, they'll have some sort of symptoms or adverse events associated with that. So looking at it, MRA as opposed to MRI has been shown to be the imaging modality of choice. It has a very high sensitivity and specificity, but the gold standard for diagnosis really is arthroscopy. There's a lot of artifacts that could come up in these MRIs, MRAs that can, shield or hide really what's going on. So, I've told this to people as well. You get these MRIs, it opens up a whole can of worms. We could go into in other episodes these whole MRI machines and even some of the damage that they might be doing. But, it is an imaging modality, right? So not all imaging could show everything that's there. So you have to take everything with a little bit of a grain of salt, especially when it comes to something in the shoulder where all these structures are so compact, right? Everything's just so close to each other. You get a little bit of artifact or a little bit of movement while they're in the MRI machine, and that could throw off some of the readings. So again, these are some of the things from more of a surgeon, physician perspective that we need to look at. But again, as far as education is concerned, we should, as physical therapists, we should know some of these things to have a better sense of what's going on with the patient and what they should expect and calm them down overall. As far as surgery is concerned, there's different kind of methods that are associated with it. Even the surgeons mentioned that when someone has a partial thickness rotator cuff tear, they would generally like them to be seen non-operatively for 3, even up to 6 months, especially in younger people and atraumatic individuals as well. So these are all options that go in favor of physical therapists. I think we need to utilize our skill set a little bit to really shine through and help these patients out. So a little breakdown on the surgery, a little bit on the biologics, and then we'll go into a little bit more about just this patient case and how it all fits in. So there's a lot of different surgical options. The major decision comes to whether the patient would benefit from a rotator cuff debridement with or without subacromial decompression, or if a repair of the partial thickness rotator cuff tear is indicated. So with that arthroscopic debridement, with or without an acromioplasty, which would help that subacromial decompression, you're looking at a conversion repair or an in situ repair. So I didn't realize that there were these two different types, I'll be honest. So with the conversion repair, what they do is they take that partial thickness and they cut it even more. And you create a full thickness tear, and then they repair it after that. An in situ repair preserves that existing anatomy, and then they repair it based off of that. So this article states there haven't really been any studies to really show whether one works better than the other. So still up in the air, but just something interesting to know going forward, whether they get that conversion or that in situ repair. So two different options there, main options really. And finally, biologic adjuncts. This paper goes over a little bit about some of these things. We have these hot topic, hot button issues. You got PRP, just something to throw into some of these, growth factor stimulants, really what's going on, right? So stem cells, platelet-derived growth factors, PRP, as we had discussed. And essentially what they said was there's very little clinical support for these biologic adjuncts in the treatment of rotator cuff disease, with no clinically significant difference shown in patients. So, when you get that hot shot surgeon who tells their patient, "Oh, I got to shoot you up with some growth factors," just tell them some of the things. There hasn't really been studies to show this, but again, that all comes back to the education piece that we've mentioned before. So that's kind of my article, a brief little summary about it, breaks down some things from more of a global perspective, talking about rotator cuff disease, partial thickness tears. And with that, I kind of want to have a little dialogue with Corey about how we could take all this stuff and bring it back to the patient case. So, Corey, based off of your article, after this article I discussed, how would you, I don't know, it's a tough question, but how would you just synthesize all this and sort of, bring it back to this case?
Certainly. Again, I think the big basis of what we were trying to get at with these two articles is how important the educational piece can be. And with this patient, of course, we didn't give you any information on his range of motion or on his special testing or anything like that. The big factor, I think, especially on day one for this patient, is that he is in a high level of pain and a high level of fear.
Right, and not to cut you off, but even I think that's all that. I don't want to say matters, because range of motion and all that matters, but I mean, at the end of the day, you want to treat some of these symptoms, so.
Right. And that matters for this patient right now.
Right.
He doesn't care if he has 150 or 170 degrees of flexion at this point. He's saying, listen, I am, he might not be saying this, but you can tell that he is terrified to move this arm because he doesn't want to make anything worse. And you know what? I think this is probably worth another episode too, but sometimes the doctors can set you up for failure. They might have said to this guy, "Oh man, your rotator cuff is shredded up," or "You got the shoulder of a 7-year-old." And I think it's worth talking about how negatively those kind of terminology can affect somebody's psyche and somebody's confidence in their movement.
Yeah, definitely. I mean, yeah, I'm kind of chuckling a little bit over here as you say that, because it's true. These patients go into a lot of these surgical offices, and it's it's almost like they get put down in a way, right? It's like, wow, you have this pain, you have this tear. It's like these people are just getting negative information just thrown at them, and sometimes all they need is someone to say like, hey, with this kind of injury, a lot of people recover. It's okay. This happens to people, especially 56-year-old, right? We just saw a 5th decade of life. There's a huge increase in degeneration in those shoulders. So, I mean, people are going to have this kind of stuff. So, again, education and sort of just bringing them back down, right? Just bringing them back down.
And to be sure, there are surgeons who are absolutely wonderful with describing on how people should go through conservative methods of treatment first. But I think really there's two ways you can go about explaining these kind of things with patients. For this patient specifically, he's got his MRI. He knows he's got a tear. He might even know which specific muscle is torn. You might want to go into a little bit of the pathoanatomy stuff with him briefly to explain, listen, we know that conservative treatment has shown to have a high rate of success. People are doing very well. You can go into some of the surgical options with him. Kind of give him a whole spiel of what happens. Let's say you didn't do well and you end up going into surgery. This is what happens. Maybe that's a talk for down the road. But so there is a patient who I might go into a little bit of the pathoanatomy with. But if I was seeing this patient and he didn't necessarily know what was going on, I might try to really pull back on all that stuff and not make it so much about the anatomy or the pathology. You're going to get those questions, of course. So, what's wrong with my shoulder? Like, what's going on? But really, I try to bring it back to the patient's function. And specifically, I try to pick out a few different things that we can change each visit, whether it's producing a contraction into external rotation or it's just lifting that arm up off the table. I try to pick something and see if I can change it from the beginning of the treatment to the end of the treatment. People have called it like the asterisk sign, things like that. Mm-hmm. And I think that's a good way of going about it sometimes, because you can show this patient what kind of value you can bring to them.
Right, definitely. And even just moving their arm, right? Just showing them like, hey, this is okay. You can do this.
Yep.
I think it's very beneficial to them. These are all points that, today we kind of discuss more of like the global aspect of rotator cuff disease and severity and, talking about pain, talking about outcomes, things like that. We didn't go too heavy into, nitty gritty stuff, treatment, all that and whatnot, but stuff to go into in further episodes for sure. Major takeaways though, Corey, if you had to break it down 1 or 2 points, what would you drop it down as?
Sure. I would say, honestly, it said right in the title of that article, pain intensity is not associated with rotator cuff severity. That's one big take home right there. Take home number 2, I would say for me, is that surgery is pretty low on my things I'm trying to bring people to right away. You know what I mean? Like, surgical options are there for sure, but I'm constantly trying to show patients that, listen, like you said, MRIs cannot always give the most accurate information. You should always have some sort of conservative treatment option first in the shoulder.
Yeah, definitely, and I have to echo those points as well. My takeaways for sure would be, based off of our discussion and everything we had talked about, is getting the facts to the patient, giving them another opinion, giving them another voice. I think as physical therapists, we oftentimes are the ones who motivate people. We're the ones that empower people to do the things that they want to get back to and even go beyond that. So I guess give them the stats, tell them, like Corey had said, not much of a correlation, if any, between pain and rotator cuff tear severity. Take some of the stuff that I had discussed as well, right? Usually we want people to go through some conservative care, and if that tear size is below 50%, a lot of them do very well, so get these markers down, get some goals set, and move forward with that.
For sure. Now, again, what we want to do in these episodes is not so much bore you with a ton of research-based stuff, although I think it is important to go through. But I think tying it into a patient case is helpful, because we try to make them general enough so you can apply them to a lot of different patients who might be presenting with shoulder pain, especially with a rotator cuff tear. And going on our whole title of the PT Forensics, what we want to start to do is really start to analyze some of the evidence, especially on some of the more controversial things, or, quote unquote controversial things like maybe dry needling or ultrasound, and start to examine the evidence from both sides, for and against, and see if we can come up to a consensus of how we think folks should be treating it in an evidence-based manner.
That is a perfect summary of what we're planning to do, Corey. I really appreciate everyone listening. This is the very first episode, intro right here. We are going to go forward with some more information. We are going to break down things more going forward. So hopefully another episode coming at you real quick. Thanks everyone for listening.
Thanks again.